everything has to be done in a sterile fashion because we're injecting the disc. As you can see, the prep and drape and the CM cover knee, it's almost like a surgical procedure. So this is the kit. I will be taking the two 30cc syringes and the centrifugation canister and 10cc syringe. Here we are taking 30 cc's of heparin, which is 1000 per ml, 1000 units per ml. This is mainly used to flush the syringes, and I'm going to put this, I'll show here, Jen. I'm going to put this in the well. I'm creating a well so I can use it to bathe the stylet, which I'll show you later. And next, I'm taking the ACDA. This would be around 20 cc's. This is the most important step because you want to do whatever you can to avoid clots. You have to pay meticulous attention because once you have clots, it's game over. You lose all the cells, all the MSCs in the clot. So, and then we have 10 syringes like this with 6 of the 10cc syringes. So first I will take the heparin out, basically coating the syringes with the heparin, and then we'll use the 1cc ACDA. This is going to be the anticoagulant, and we do that for every syringe. Any plastic that is coming in contact with the BMA or the aspirate, you want to coat it with the heparin, including the syringes that we're using to collect the bone marrow aspirate, which is the 30cc syringe, as you can see here. So coated with heparin. This does not need any ACDA. And then we also bathe the stylet in the heparin well that we created, and then flush the bone aspiration needle. This is a 15 gauge needle. So as you can see, we're doing the right-sided iliac crest aspiration. The C-arm is oblique contralaterally away from the right side. And then we get the picture of the iliac crest. And we like to aspirate from the upper third of the iliac crest because we feel that that area has more stem cells than the middle third or the lower third. So we're using a 22 gauge 3.5 inch needle for infiltration of the iliac crest, little stick body, and local infiltration with a 30 gauge needle. And I don't inject any more until I hit the iliac crest with the 22 gauge 3.5. Some pressure. So that's numbing your iliac crest. Show that, Jen. So as you can see, the needle is on the iliac crest. And then show here, Jen. And then I'm going to use 5 cc's of 2% lidocaine. Some pressure buddy. This is just the numbing. And keep turning the needle as I inject because it's a curved needle. So I want to get a 360-degree infiltration. Aspiration needle. Feel some pressure, buddy. All right. He has some pain, but he's not going to remember because he's already got 10 milligrams of Versed. Can show the serum picture. So the needle is lodged on the iliac crest. So I'm going to start the drilling, and as soon as I enter the iliac crest, which is barely a few millimeters, I stop. And then we take the pre-filled syringe with ACDA, which has been flushed with heparin or coated with heparin. Rapid pull may hurt. But has to be rapid pull. Mix the heparin, ACDA with the aspirate. He's a younger male, so he's going to have more pain than usual. So I took that stylet, which is coated with heparin. As remember, I put it in the heparin well. So I'm going to advance now another centimeter. Take the stylet out. Show this, Jim. You can see the stylet is bathing in the well with heparin. Again, it's going to be another fast pull, this time 3 cc's. Then mix the heparin with mix the aspirate with the ACDA. Then again, put the heparin coated stylet back, and then advance another centimeter. Show that, yeah. That's how it looks on the floral. Let me take a picture. And then another rapid pull for the rest of the syringe. And this one, I empty it into the 30 cc syringe, which has been coated with heparin before. And I mix it well, so there's good mixing of the ACDA with the bone marrow aspirate. Put the stylet back. And then remove the needle. So after the first 10 cc aspiration, empty the stylet, put it back in the heparin well. This is important. I flush out the needle with heparin and then put the stylet back, and now we'll do the second aspiration. So this is the second aspiration. This time we'll go to the higher, the same skin puncture, but the bone puncture is going to be higher. Show that, Jen. As you can see, the needle is now angled superiorly. So we're going to a different spot. So now advance a little bit. As soon as you enter the periosteum, you stop. And the same process again. This is another pre-filled syringe with ACDA, which has been flushed with heparin. Again, it's going to be a quick, rapid pull. Mix it well. And it's the same process. Again, Jen, show the serum picture. Take another one. So you see how it's in a totally different area. Then come back here. And now we're going to advance another millimeter. As you can see, this is a much smaller needle than the 11 gauge Jamshidi. So another quick rapid pull. Another 3 cc's. Looks like it's tolerating it better now. And mix it well with the heparin. And then another 1 cc advancement. You get the total about 10 cc's, which is basically 9 cc's of the bone marrow aspirate and 1 cc of the ACDA. So we got the second syringe. And again, we'll be emptying that into the 30 cc syringe. Mix it a couple of times with the heparin to avoid any clots. And take the needle out. just like before, remove the stylet, flush it again with heparin, put the stylet back. So now we'll go for the inferior part of the iliac crest. See, the angle is downwards. Show them the CM. So it's a totally different spot. We barely drill it in. I'm in the periosteum. Again with the, this is the third aspiration from the right iliac crest. Again, this is from the inferior part. Quick rapid pull. Mix it well. Yeah. So we'll advance it 1 centimeter again. Most of us are very close to temperature. Right. So this is the second aspiration, 3 cc's, quick rapid pull, mix with heparin. Again, take the stylet, which is bathed, show here, Jen, which is bathed in the heparin. Put it back. And we'll do advance another centimeter for the third aspiration. Jen, show them the serum. Actually, yeah, show them the CM one more time. So that's the final position for the third aspiration, and then quick aspiration again until you fill the syringe, and then empty it in the 30 cc syringe. Mix it well. So we're done with the aspiration from the right iliac crest. We got 30 cc's. And we will be doing exactly the same thing on the left iliac crest for another 30 cc. Needle coming out. As you can see, this is such a smaller needle compared to the 11 gauge and sheety. So flush the syringe, sorry, the needle, dial it back. It's ready for the next draw. This time we'll show you the right iliac crest aspiration. So now we are infiltrating or local anesthetic for the left iliac crest aspiration. Little stigma, it's the numbing, doing really good. You feel some pressure. So as you see, for the left iliac crest, the C-arm is rotated away from the iliac crest. Try not to move. And then, yeah, go ahead and show them that. So the needle is now lodged onto the iliac crest, and then we will be injecting it with local. We'll rotate the needle every 2 cc's, so we get a 360-degree local anesthetic. We will be placing the needle. Sorry, buddy. Thing is, you won't remember. And show that, Jen. So now it's lodged on the iliac crest. As you can see, it's in the superior part of the iliac crest, the superior 1/3. As soon as we're going to drill it, as soon as we enter the periosteum, we're going to stop. And I'm in the periosteum. Show that. So as you can see, the needle is going laterally, so I'm going to readjust it so it's in the dead center. After readjusting, It's still lateral, so I'm going to readjust. I think it's slipping off the bone. So that looks much better. So we'll do the first aspiration. Quick rapid pull. Sorry, buddy, this hurts. Mix it well. Just dial it back. Do the second aspiration. Advance the needle a centimeter. Show them that. Okay. So as you can see, it's in the middle of the iliac crest. I'm talking about the medial and lateral plates. It's in, you want to be as central as possible. Again, rapid pull for the second aspiration. Mix it well. Advance another centimeter for the third aspiration. So this is the second 30 cc syringe. Empty the aspirate, mix it well. Take the needle out. Trouble action on. Make sure this is tight. There. Again, every time, bathe the stylet, flush the needle. So now we will be going superior to the first bone puncture site. I can see the angle of the needle is more superior. Show that, Jen. So in the C-arm, you can see it's more superiorly angled. Just entered the bone. Show that, Jen. It's a little medial, but it's okay. I can adjust it. Second aspiration. Show here, Jen. Quick pull. Sometimes that happens. Mix it well. So now I'm gonna advance it a little medially because it's too, sorry, laterally because it's too medial. Show them that, Jen. It's a little closer to the medial wall. So I'm just gonna angle it a little laterally. Advance 1 centimeter. Show that. As you can see, it's more midline now. So we'll do the second aspiration. Quick pull. Second aspiration, mix well. And we'll do the third. It does take time because you're doing bilateral iliac crest, a total of 6 bone punctures, 3 in each iliac crest, and a total of 18 aspiration sites. So it does take time, as you can see. It has to be done very meticulously to maximize the extraction of MSCs that we're seeing. But I think it's worth it to give the best results for patients. Take this out. So now I flush the syringe, and we'll go for the third bone puncture, but this time we'll make it inferior. As you can see, the angle is inferior. Jen, show them that. Show them that. That's the inferior angle now, as you can see. So we'll advance it. In the bone marrow, just penetrated the periosteum. Do the third aspiration, this time from the inferior part. Mix well. Do the second aspiration. Show them the thing. And do the second aspiration. Then we'll do the third. This should be the end of the bone marrow aspiration. I think we tolerate it really well. So now we take 30 cc's from each syringe, mix it well. As you can see, we have a female to female connector. We're going to mix it well, mainly to get, let me show it this way, because we're going to send this BMA sample for testing, so it gives us a good representation when you mix it well. And then I'm going to take 1 cc for testing. On the side, and empty this syringe, and then we're going to hook this up to the filter. And then filter the BMA into that empty syringe, looking at about 60 cc's, which is 54 cc's of the aspirate and about 6 cc's of the ACDA. And then use the rest of the BMA in the 10 cc syringe. Filter it. Filter that. So we got almost everything. And this is the sterile centrifuge canister. Into this filtered BMA. Into this canister. So you keep this canister in this plastic sterile cover because you want this canister as clean as possible, because you don't want blood flying all over the centrifuge. You want zero blood on this canister. So clean everything from the top. My fingers are not touching the canister, so there's no blood on it. So this is, blood is removed. So take a alcohol swab, clean it. And I'm going to hand it to him so it's all clean. I'm just going to put it there, go and close it. And then it's 6 minutes, 4200 RPM. I will be doing a second prep before putting needles into the spine. Hold my an extensive prep again. I'll be doing L5S1 disc now. He needed extreme angulation, cranial angulation to maximize the disc space. He's got actually a pretty good disc. Show that, Jen. Actually has a pretty good disc at L5S1, so we should be easily able to get in. We are not doing the double needle technique. Little stick buddy, try not to move. It's the most important part. And the L5S1 disc is the most challenging disc in this most challenging part of the procedure. As you can see, iliac crest is not challenging at all, especially when you do it on the floor roll. It becomes very, very easy. Show that. So as you can see, right next to the SAP, and I'm in the disc right now in the annulus. I'm going to advance a little bit more. So that's in the disc. Can I see caudal, please?
Yes.
And then show that, Jim. So we're going to do caudal quite a bit to max it. That's good. That's good. To maximize the L45 disc. Pull towards you. Okay, cranial. So as you can see, the L45 disc is not maximized. We're doing a little cranial. It's getting better. Some more cranial. That's good. Much better. Touch more cranial. And then that's beautiful. And then also I want the SAP to be come on in a little bit, and then oblique just a touch towards you. I want the SAP to be in the middle of the vertebral body. Ideally, that's good. I should do it, I think. That's pretty good. So we're going to start right next to the SAP. Show the agent. Right next to the SAP. Okay, show here. Little stick body plate. All we use here is local for the skin, nothing deeper. Most of the time they don't need it. Show that, Jim. So you want the needle right next to the SAP in the middle of this space. So readjust and advance, and so very close, almost there. So I'm in the disc right now. It's going a little superior, so I'm just gonna turn the bevel down so it goes inferior. That looks great. So now we'll go after the facet joints. You can see it pretty well here. Lead towards me. Take the cranial off to him.
Yeah.
I will show there, Jen. So now we'll be going after the L5S1 facet. Little stick body. Pressure. Doing well, Mike. From the joint. Let's go for L45. Like here, yeah. Little stick buddy. Doing great. That's in the L4 for the set. Okay, let's do the right SI joint. So we're doing the SI joint now. Little stick mine, just the numbing on the right side. Try not to move. We're doing great. That's in the right SI joint. Go north a little bit, Kim. So we're doing the left SI joint. Little stick buddy. I'm in the joint on the left side.
Yeah.
So I'll be taking out the canister with my left hand. So I'm going to assume that this is not sterile anymore. This part is exposed. With my right hand, we're going to take the alcohol swab and clean the top. Wait for about 30 seconds. Layers. The top layer is the fat from the bone marrow. The light red is the PPP. You can see the buffy coat under the PPP, and the bottom is the RBCs. So our goal would be to remove most of the PPP and of course the fat, and then also want to get the white buffy coat layer. So on him, I'm going to inject 2 cc's in each disc, so I need 4 cc's. Then 0.5 cc's in the facet, so that's 2 cc's, and 1 cc in each SI joint, that's 2 cc's. So I need about 8 cc's of bone marrow concentrate. So I'll show you how to get about 8 cc's from this. In about 30 seconds. Remember, my left hand is no longer sterile. My right hand is sterile. I got the sterile syringe, was handed over to me. And I'm going to now remove the PPP. So I want about 8 cc's total. So first we'll aspirate most of the PPP out. I want to get it about a few millimeters above the buffy coat. I don't know if you can appreciate it, but I can see it well. It's hard to see probably on the camera. So the plunger is about a couple of millimeters above the buffy coat. I'll stop there. So cap this with the sterile needle. Put it down. And then this is the most important part. Again, my right hand is still sterile. Left hand is not. This is all sterile. So now let's see how much PPP we get. So I'm aspirating the PPP. So we got about 4 cc's of the PPP. So I'm going to take about 4 cc's of the RBCs. So as you can see, you're getting the mixture. So that's about 8 cc's.
4 and 8.
So again, cap this with a sterile needles. So everything inside is sterile, outside is not. Change gloves, and I hand it over to him. Then I'm going to take calcium chloride. Because we're going to mix calcium chloride to form a clot. Again, everything has to be sterile. And since I'm not sterile anymore, I'm going to wear new gloves. I'm going to take the sterile 10 cc syringe from the spray, and then Kim is going to empty the BMC now, so it all remains sterile. Remember, the outside is not sterile, but the BMC is sterile. Now everything is sterile. It's very important to maintain strict, meticulous attention, especially when you're injecting the discs. So I'm going to send about 0.5 cc's of the sample for the BMC TNC count and the viability. Remember, we did send 1 cc of the BMA earlier, so that's about 0.5 cc's. Just going to leave it here. And then I'm going to mix this with calcium chloride. So this is about 7.5 cc's I have here. Make it around 9 cc's, a bit lower, 1.5 cc's. Usually it's 1 cc per 10 cc's. It takes a while for it to clot even after you mix the calcium chloride, which is a good thing for us. So I'm going to take about 2 cc's in a 2 cc syringe and inject his L5S1 disc. Stop it here. This is the L5S1 disc. We're going to inject very slowly with the 2 cc syringe because I think the pressure will be less. You don't want to overpressurize the disc, and this is usually a painful part for the patients. It's almost like a discogram. Let's see how much volume I can put in. Especially if it's a leaky disc, it goes in easily. It's not too bad. I see some pressure, but the key is to inject it very slowly. You okay, Mike? Show the CM picture. As you can see, the L5S1 disc, the needle is just lateral to the spinous process. You can see the spinous process at L5. I did not get a lateral view. We did not inject any dye. So we know based on this picture that it is in the pulposus. So I injected about 1.5 cc's. I'm getting a lot of resistance. So the last half a cc, as I pull the needle out, I'll inject. That will be the annulus. Take a picture. So that's the annulus. As you can see, the L5S1 disc is out. So we've injected about 2 cc's in the nucleus pulposus and about half a cc into the annulus. So this now is the L4-5 disc. And as you can see in the image, it's just lateral to the spinous processes at L4-5. I'm going to start injecting slowly. Try to avoid a lot of pressure. You okay, Mike? All right. Not getting much resistance for this disc. So I'm going to inject everything intranuclear. It is coming out. Let's check. So now we're injecting 0.5 cc's into his right L4-5%. Interestingly, he had more pain there than the disc. Now we're injecting his L5S1 disc. Then comes, actually, no, let's do finish this. So this is the L4-5 on the left side. Pressure, everybody, bear with me. This is the left L5S1 facet, 0.5 cc's. You still on?
Yes.
So now we will be injecting his right sacroiliac joint. Pressure Mike, sorry, doing great. And then the left sacroiliac joint. We're all done.